I'm sorry.
I think for the first short while, it probably will be.
Yeah.
Somebody named AV just joined us. Good morning, AV. Okay, that reminded me to mute everybody. We'll wait another minute because I'm seeing a paucity of Mount Sinai people here. Hey, Neha, do you think our fellows are coming, or?
They should be. I'll just confirm.
Thank you, AV, whoever you are. A good way to avoid having to answer a question is to say that you're on your phone and you therefore can't see the tracings. Okay, let me share my screen. Actually, I'm going to first mute everybody, but everybody can unmute themselves when they would like to. Okay, let me. Okay, can everybody see the screen okay?
Yes.
That's good.
Okay, great. Okay, so 7:01, we'll give it one more minute and then we'll get going. Okay. Let's see, a nice gentleman with a big beard there. All right, why don't we get going then? Okay, so in keeping with our approach the last few weeks of reviewing an arrhythmic medication, today we'll start with Fleconite. Fleconite, you will recall, is a class 1C antiarrhythmic agent. It affects the flow of sodium channels with prolongation in the action potential. You can see here on a drawing of the action potential, we see the effect of this agent with the class 1C prolonging depolarization and having fairly little effect on repolarization. And this is in fact why it is that when you're on Fleconite, the thing that we're most concerned with on the electrocardiogram is prolongation in the QRS. Typically, you'll see a new right bundle or widening of a bundle. That would generally be a bad sign that you are approaching toxic levels of Fleconite. Okay, the brand name of Fleconite, which I mentioned because we surprisingly don't spend a lot of time thinking about it, is Tambicor, in case that ever comes up. And it's used for multiple things. I think it would be fair to say, however, that most of the time, Tambicor or Fleconite is used for SVTs or supraventricular arrhythmias. It can be used pretty much for any kind of arrhythmia, AVNRT, WPW-related tachycardias, and of course, ectopic atrial tachycardia or EAT or any atrial arrhythmia. I think in pediatric use, it would be fair to say that that has been the most common usage of this agent. Oftentimes, ectopic atrial arrhythmias are only responsive to Fleconite. And that's disappointing, but it is the fact, and I'll go over why it's disappointing in a moment. It can be used for VT, particularly for RV outflow or ARVD types of VT, but generally speaking, because most other agents are superior for this indication, we don't usually use it for these causes. I think Barry sometimes has some VT patients on Fleconite, but generally speaking, we don't use it for that purpose because there are other agents that are equivalently good that are probably less dangerous. It has also sometimes been described to be used in Brugada syndrome only as a diagnostic tool. You would never give somebody with Brugada syndrome Fleconite. It would be dangerous, but you can potentially see EKG changes with it, which could help in the diagnosis. Okay, the mechanism of action, again, is it slows the upstroke of the cardiac action potential, reduces excitability. The greatest effect is on the His-Purkinje system and the ventricular myocardium, but as I mentioned earlier, in fact, we use it predominantly clinically for atrial arrhythmias. It can also inhibit the ryanodine receptor 2 and affect calcium ion handling, and it might be useful in CPVT. In fact, some authorities think it's the first choice for CPVT. I'm not sure I agree with that, but I think it's certainly true to say that for some difficult CPVT patients, for sure it is an agent that is used in those circumstances. In regards to metabolism, it has a high bioavailability. The peak serum concentration is 1 to 6 hours after ingestion. That's important if someone is toxic with the agent, has a plasma half-life of 12 to 24 hours. And steady state is typically achieved in 3 to 5 days. Mostly it's eliminated by the kidneys, and so knowing your kidney function prior to starting it is important, and adjusting the dose for kidney insufficiency is important. The rest of the elimination is from the cytochrome P450 mechanism of the liver, and it can decrease the metabolism of other agents that are, excuse me, metabolized by the P450 system. Now, this is the biggest problem with Fleconite, is that it has a very narrow therapeutic index. Fleconite has a very high incidence of proarrhythmia if not used properly. It's particularly more common when there is hypokalemia. And the signs of Fleconite toxicity are PR prolongation and QRS widening. And this is the reason why when you're beginning a patient on Fleconite, most often, certainly in children, I think it would be fair to say that we routinely start this in-house in an observed area, typically on telemetry. And we are looking for a daily 12-lead EKG, looking specifically at the QRS duration and the PR duration, because both can subtly increase and can be a sign of elevated Fleconite levels and impending problems. It is particularly, it is a negative inotrope in general. And if you have a patient who has low ejection fraction or poor function on the basis of an arrhythmia, typically the benefits of terminating the arrhythmia are so great that any negative inotropy is far outweighed by the benefits of being in sinus rhythm. And typically patients with poor function from, for example, a tachycardia-induced cardiomyopathy, as is common with EAT, will actually improve with Fleconite. However, if you have a patient who has a primary cardiomyopathy, Fleconite would generally not be a great agent because it can worsen ventricular function, not to mention the fact that it is proarrhythmic if not dosed perfectly. And so one needs to be very cautious with its use. It can also increase the threshold on pacemakers. And so if you're using Fleconite in a patient who has a pacemaker, it is important to monitor the pacemaker thresholds because they may rise with the use of this agent. Okay. I thought I would review a case report from a few years ago on how to manage life-threatening Fleconite overdose. I'm mentioning this case report because, unfortunately, having now practiced as an attending for 23 years, I can tell you I have seen life-threatening Fleconite overdoses many times. And so it is an extremely effective and helpful agent, but it absolutely can be very dangerous. And so I would caution anybody who's listening or watching this to be very careful about it. And I'm going to go over how they identified and then manage this, because if you are working in an ICU setting or working as a pediatric electrophysiologist, you will at some point, unfortunately, have to deal with this issue. In fact, it happened in my prior job at least 3 separate times in the hospital. I've seen it, and I've seen it from patients as an outpatient who received too much fleconide, and it has happened here as well at Mount Sinai as recently as about 6 months ago. And for the fellows from Sinai, I know you know who I'm speaking of. So this particular case report was a 23-year-old with a history of symptomatic PACs and atrial tachycardia with a bicuspid aortic valve and no stenosis or regurgitation. Patient had a history of depression, and I would caution the use of this agent in anybody who you think is any potential for overdosing this medicine. It's a very effective way to kill yourself, I would think. 1 month prior, the patient had a normal ECG and echo and ingested an unknown quantity of fleconide and amphetamines. This is the electrocardiogram upon arrival. In this paper, you can see it's a very wide QRS. It is, in fact, sinus rhythm with a very long PR interval. You can see that here. This is a very worrisome sign in somebody who is taking fleconide. Patient initially, according to the report, was conscious but became unresponsive. And rapidly, this wide QRS rhythm degenerated to pulseless VT and VF, requiring resuscitation and multiple defibrillations, and the patient was intubated. One thing I wanted to mention is when you're starting a patient on fleconide, particularly in the hospital, it's useful to check telemetry frequently. In every case that I've seen of people who have arrested from fleconide overdose, if one had looked at the telemetry and critically in the 2 to 4 hours prior to the arrest, you could have identified that there was a problem that was brewing, either by a very long PR interval or a very wide QRS or a higher grade AV block than what you had before. So it behooves us to, when starting this medicine, to do it on telemetry and to actually look at the telemetry. It's very disappointing, obviously, when somebody arrests, and when you go back on telemetry, you see that there was quite a bit of evidence that this could have happened and perhaps you could have interceded. So the question then is, what do we do now when we have this uncontrolled ventricular arrhythmia from fleconide toxicity? Well, what they did, first of all, was gastric tube suctioning because there was a history of ingesting a lot of pills. They gave hypertonic saline, potassium and magnesium supplementation. They hyperventilated to maintain alkalosis, and they administered intravenous lipids. The QRS transiently narrowed, but then it widened again. This is what the tracing looked like. Now we're really getting into some scary looking electrocardiograms. And because they could not get control adequately, they put the patient on ECMO. And fleconide level at that point was 2, therapeutic being up to 1. The echo showed severely depressed function. And eventually, after a number of days, when the fleconide level had fallen and the heart function recovered, the patient was decannulated from ECMO on hospital day 5. And this is the patient's electrocardiogram following this horrible experience. And we see first-degree heart block, but otherwise the tracing is not too abnormal. So what are the takeaway points? The first point is that fleconide toxicity is real. And if one is toxic from fleconide, there's a 10% mortality in the literature. The treatment of fleconide toxicity is, first of all, sodium bicarbonate infusion to alkalinize the blood, as well as sodium administration. Intravenous lipids are important. They can decrease the amount of drug available to the sodium channels. We have used them before and used it in our own experience here at Sinai, can be effective. It's hard to get lipids, though, on the fly. We were able, actually, in our experience, to take the lipids of another patient that had not yet been used to treat. Amio and lidocaine have been reported to be effective for fleconide toxicity. Not sure I would do either of them. I've never personally done that. Transvenous pacing is a possibility. Remember, of course, that small infants cannot be paced transvenously. If you place a transvenous pacing catheter in an infant less than a year of age, you will perforate the heart within a few hours. ECMO is sometimes your only option when you cannot, despite all of these maneuvers, get control. And dialysis is not effective at removing fleconide, only time. And this last point is the most important point of all I'm going to say on this topic, which is that when you are giving Fleconite to an infant, and it's made as a compound, it is very important to remind the parent that the bottle must be shaken very aggressively before every dose. Remember that Fleconite does not come commercially available as a compound. So when it is given for small children, by definition, the pharmacist is mixing it up and typically taking a number of pills, crushing them, and putting them with some kind of a simple syrup. And the problem that I have encountered and others have seen is that the bottle, has these pill fragments. And so if the family is not aggressively shaking prior to each and every dose, by the time that the patient gets to the bottom of the bottle, the concentration of Fleconite is extremely high. And that has been, in my experience, the most common reason that outpatients get into trouble with Fleconite. So patients of mine who are on Fleconite know that I am, if anything, I overdo it in regards to telling the family to shake the bottle. Every single time I see them, I remind them of that. And this is one of the few medicines where I will tell a family that really only one or two people should have the responsibility of giving this medicine. This is not, for example, a medicine that should be administered by a babysitter. Unless, of course, you have great faith and trust in the babysitter, because this really has to be done properly. Because, again, the therapeutic index for this agent is very narrow. It is an excellent agent, but it is also a dangerous one. So keep that in mind. Caution is always a good idea in using this agent. Okay, let's move on to the electrophysiologic potpourri today. So this is a tracing of one of my patients from 19 years ago. This is a 20-year-old who had hypertrophic cardiomyopathy, and we did a generator change of her ICD. Now, in those days, we would always admit people to the hospital after a generator change. Today, we would not do that. And this patient is programmed to shock for heart rates over 220 beats per minute. And we're here on post-op night number 1. And this is what we observed on telemetry. So why don't I ask, is Namrita on the call this morning?
Good morning.
Hey, Namrita, how are you?
Good, how are you?
I'm very well, thank you. So what do you think about this? What do you think about my ICD and whether, what's going on here?
So it's wide complex QRS.
Mm-hmm.
So initially the heart rate's around 150,
Mm-hmm.
and then it switches to like 200,
Mm-hmm.
over 200.
Yeah.
And it's monomorphic when it switches.
Well, it's hard to say, but
Monomorphs, like, yeah.
I think it's fair to say at the end it is certainly not monomorphic, right? I mean,
Yeah, down here. So it turns into a wide QRS rhythm to VTAC to VFit.
right. So you notice in this tracing, there is a worrisome absence of something. What's missing on this tracing in this patient in whom I just changed the ICD? What should an ICD do when it sees this?
It should shock.
It certainly should. Are you observing a shock in this tracing?
No.
No. And in fact, there was no shock delivered in this tracing. Thankfully, the patient was in the hospital and was on telemetry in an adult telemetry unit. And the arrest team rapidly came and externally defibrillated her to sinus rhythm. And I received a phone call that this had happened. So what do you think is the likely reason? I mean, I think we would agree that this heart rate exceeds 220 beats per minute, right? So why do you think it is that this happened? Why is the device not shocking the patient?
Is the upper limit too high? So it's at
Well, it's at 220, and that's always a good thought. You know, was the rhythm slower than the rhythm that that the patient had? And I think the answer is no. This is quite a bit faster than 220, right? This is going.
Yeah.
Some of these beats are at 300 beats per minute. So the answer is that this device was not sensing this tachycardia. Presumably, the R wave was not large enough for the device to detect that the patient was in tachycardia. Now, whenever we do a generator change, you all probably are aware that we routinely assess the lead in the operating room at the time of the generator change, because you would never want to place a new device with a bad lead. So this patient's R wave, which is the size of the electrogram recorded between the two electrodes on the tip of the lead, was 6. And generally speaking, the bigger the R wave, the better. So we would want a very large R wave. But generally speaking, I think it would be fair to say that most electrophysiologists would say that an R wave greater than 4 millivolts is sort of the minimal acceptable R wave. That the majority of the time, if the R wave exceeds 4 millivolts, it is very likely that the defibrillator will sense the tachycardia. And in fact, in this era, we used to induce VF every single time we would change a generator, and we would test the device and its ability to detect and defibrillate a patient. And in fact, we had done that in this patient, and it worked very well. But the thing is that when you induce VF, or you try to induce VF in the operating room, you never really know if the VF you've induced is what will be a clinical VF. Additionally, in this patient, we actually were only able to induce VT. It was a fast VT, and so the device detected it and shocked the patient out during testing. But I think it's fair to say that this particular VF, the device was unable to sense. So now I have a 20-year-old who has thankfully survived this scary experience. I might also add that in the present era, we would not have even tested, we would not have defibrillated the patient in the OR. We would usually just, if the R wave was adequate, if the impedance was adequate, if the threshold to pacing was unchanged, we would normally not test a defibrillation threshold or safety margin test. And so this is, but in some way you could say, well, I guess this case proves that that was a mistake to do, because it didn't actually predict what would happen when the patient clinically had arrhythmia. But for sure, we would never admit somebody to the hospital for a generator change. And it was her luck that at that time, we used to admit people, and she was being observed and got defibrillated externally. So now you have this patient so we go back and we interrogate the device, and we see that the R wave is still 6, and the pacing threshold is still low, and the impedance is the same. So it suggests that the lead has not been affected. One of the things we would be worried about during any generator change is that we've inadvertently injured the lead. That's always a concern and a risk during any pacemaker surgery. But in fact, we had not done that. The lead was working fine. So what would we do now? So I basically have somebody who, through all measurements of the lead and the device, appears to have a good functioning lead. But we have this event, which is real and very worrisome. So how would you consider managing this now that we have proven that the lead does seem to work okay? Have any thoughts on that, Nimrita?
Would you increase the pacing threshold?
Well, pacing threshold is how, I think what you mean is, would I increase the output to pace? No, that wouldn't have any impact. What we're talking about is a sensing problem, right?
Yeah.
The device can't sense the spontaneous, very dangerous arrhythmia.
What about the PVARP?
The PVARP. Now we're throwing some terms out that have no relationship to anything. I appreciate the use of the term, but no, the PVARP, or the so-called post-ventricular atrial refractory period, would have nothing at all to do with this, but a good term nonetheless. Let me see here. Grace, oh, wait, somebody's making a comment here. Let's see in the chat box. Reposition of the lead, says Ray Morales. Very good idea. Only problem, Ray Morales, is that this lead has been in for 9 years. This is a generator change. So in order to reposition the lead, I would have to extract it and replace it. And back in 2001, extractions were not that common. But that is a good idea. So what Dr. Morales is basically saying is that the one option is to move the lead. Presumably it's in a location where it's not sensing very well, at least in VF. So that would be an option. But certainly if it were a new lead, if we had just put in a completely new system, changing the position of the lead would be a great idea. But in fact, this lead had been in for a while, and I might add, had successfully defibrillated her a number of times. So the answer, to be honest with you, at the time, I was not sure. I had to do a little bit of a literature search, and basically the most common approach is to either replace the lead position, as Dr. Morales suggested, were it a new lead. But in this case, given that it was an old lead, the two options would be to either extract the system and put in a new system, or a simpler approach would be to put in a dedicated rate sensing lead. And that is what we did. We actually took her back to the operating room, and we placed a new transvenous ventricular pacing and sensing lead. And you can actually, in a defibrillator, plug that into the sensing port and have there's a separate port for shocking. And so she ended up having now a rate sensing lead, which had an R wave of 20. And she still had the same shocking or defibrillator lead, and that system seemed to work. Unfortunately, in this young lady, she was only controlled. So her defibrillator worked after that. She was successfully shocked multiple times over the next few years. But whenever the patient was taken off of amiodarone, she would have tremendous amount of VT and VF. And so even though the device was successful at defibrillating her, obviously getting shocked as frequently as she was a suboptimal thing. And she started to develop pulmonary fibrosis from long-term treatment with amiodarone. She also developed a little bit of dysfunction, and she ultimately underwent a heart transplant because there was really no way to control her arrhythmia without giving her pulmonary fibrosis. So an interesting case, and just bringing up a number of issues. So showing us that although we test everything in a defibrillator in sinus rhythm, it does not necessarily reflect what the device will be seeing in tachycardia. I remember around the same time I took care of a baby who had hypertrophic cardiomyopathy, in whom we placed a defibrillator with epicardial leads. And although the device could easily defibrillate the patient, because the R wave was so small in VF, it was unable to detect the VF. And therefore, in the hospital, similar to this example, the patient had VF that the device did not shock the patient for. And we were never able to come up with a system that could protect that child. And he also was listed for a heart transplant, but sadly died waiting for a transplant and heart failure. Okay. All right. This is a 5-month-old who presents to the emergency room with this arrhythmia. And let's see if, is Purna on the line, or is she on vacation? No, she's actually deployed. So thank you, Purna. Why don't we see if Sanji Gupta is on the line? Are you there, Sanjeev?
Yep, I am. Good morning.
Good morning, Sanjeev. So what do you think about this? This is an unusual tracing.
So just glancing through at it, first of all, I'm seeing some premature beats. So we'll go through that. But
you know what? Let me just mention, I wrote 5 months. In truth, this is actually a newborn. So I apologize for lying to you. This is not a 5-month-old. So.
Okay. So it stays a narrow complex rhythm throughout. Initially, the rate is less than 300, greater than 150. It's right about halfway between that.
So what is the rate? That's true, but that's like saying I'm closer to Mars than
like
if I were in a
225.
galaxy, but
225. I'm trying to save myself from doing math in my head right now, but yeah, about 225.
no, I think the ventricular rate is not quite that fast, right? I mean, right, the R-to-R interval, it's almost 2 full boxes. So it's in the 170 range.
Okay.
180.
Sorry. And so I'm not seeing any clear P waves before the QRSs, and in some leads, it looks like I'm seeing them after.
Mhm.
So
Is there
looking at V1,
consistency?
as you were teaching us V1, you can commonly recognize things. So since I'm not sure what I'm looking at yet, I'm going to look at V1.
Uh-huh.
So I'm seeing some P waves that look retrograde, and then some that look completely undissociated.
Now, is undissociated mean associated?
Unassociated,
Okay.
like
Okay.
2, 3, 4.
A lot of
Like
double
after
negative.
sorry, after the fourth beat in V1, there's a P wave that I guess it could be retrograde, but it's much longer than the RP length than some of the other ones. So that's the one that I'm thinking is just unassociated with any of the QRSs. And then
I
if you look a
will
little bit,
tell you that Mohammed Hassan, who I believe is joining us from Saudi Arabia, correct me if I'm wrong, Dr. Hassan, says that he believes there's no relationship between the P and the QRS. You can take this under advisement, whether you agree with that or not, but that's your phone a friend.
yeah, I agree with that. They're just the P waves are all over the place. So I would agree with that statement. The QRS is narrow, and I'm sorry, you corrected the age. How old is this patient? A newborn, you said, right? So with it being a narrow complex, that doesn't necessarily mean that it is not ventricular. It still could be ventricular, but I guess I would call this QRS narrow, and I would say that this is likely. I would need to see a sinus rhythm EKG to know that this is their normal QRS, and then I would call it like coming from the AV node, like a junctional rhythm. But this could be junctional or ventricular in a newborn baby. I don't know for sure.
Right. So this could be some kind of a junctional rhythm. It's interesting, though, if you look at the P waves, let's just look at this V1 rhythm strip. There are a number of different P waves, I think you would agree. For example, we have this little P wave, and then we have this taller one. Here's one. I would agree with people in the audience that it doesn't appear as if there's much RR variability, but I can tell you on other tracings there is. So there is actually conduction. So I think that what we're looking at here is an example of chaotic atrial rhythm, and again, we're seeing multiple different P waves. You have to look at a number of these tracings, but there are a number of them here. And the definition of a chaotic atrial rhythm, which is sometimes referred to as a multifocal atrial tachycardia, is that there are 3 or more non-sinus P wave morphologies with a discrete isoelectric baseline between the P waves and atrial rates over 100 with a variable P to P, R to R, and PR interval. And it affects mostly people at both ends of the age spectrum. So in the elderly, it's common to see it in older patients who have pulmonary disease like COPD or lung cancer. And in children, it's most commonly seen in patients who are less than 6 months of age. And as many as 10 to 20% can even present in fetal life. Most of the time, patients with this structurally normal hearts. And the pathophysiology, most people feel it's enhanced automaticity. It could be triggered automaticity. It's associated, there have been studies of association with viral infections. Actually, Frank Shakeen at NYU, like 20 years ago, published a paper in which he posited that this was seen with viral infections. I think he had a paper with 4 cases of viral infections in which patients had multifocal atrial tachycardia. But I don't believe that that theory has ever been proven or disproven. The natural history is that these usually resolve by 1 year of age. And so, let's see here, we got a message here. So Raymond Morales is asking whether I would expect the PR interval to be so abnormal in this rhythm, with some being above 200. And I agree with you, Raymond Morales. I'm not sure whether or not this is, this is the diagnosis that the referring doctor had for this rhythm. I am somewhat concerned by the lack of RR variability here. None of these P waves are bringing in the QRS, but I think that this, for sure, what's going on in the atrium is chaotic atrial rhythm. The conduction, I think we would need to look at more tracings to better understand. And this patient is on telemetry at this time. So, but I will say that these can be very hemodynamically embarrassing. In this particular case, it is not hemodynamically embarrassing in this young infant. But I have seen patients who are so fast that they need AV nasal blocking agents and aggressive treatment with amiodarone or other agents. Okay. Whoops. There's another comment here. So being asked if in this condition is the origin of the P wave near to the sinus in this case. I think in this particular case, it is probably near to the sinus node because the P wave looks as if it has a similar axis to sinus in that example. Okay, I want to thank again Lieutenant Colonel Ryan Flanagan in Hawaii for this tracing, which he was kind enough to send to me. This is a 20-year-old female following a cryoablation for AV nodal reentrant tachycardia. Is Grace Kong on the line?
Yes. Hi, Dr. Pass.
Hey, Grace, how are you?
Good.
So what do you think?
So if you look at the very bottom tracing, you can see that the PR interval prolongs between the first and second beats and then drops on the third. And that seems consistent prior to other Ps that are not conducted into QRS as well. So it looks like Mobitz 2 second-degree heart block as a consequence.
2 or Mobitz 1 or?
Oh, I'm sorry, Mobitz 1.
Right. So Mobitz 1, I agree with that diagnosis. So you see that there is, Dr. Hordoff at Columbia always used to say, when you see grouped beating, you should think about Mobitz 1 or Wenckebach. And I think it's fair to say that there are groups of beats. And so as you astutely pointed out, the PR interval is lengthening until finally there's a drop P wave. And Grace, what is the level of the block, generally speaking, in patients who have Mobitz 1 block or Wenckebach?
In the Purkinje fiber?
No, actually Mobitz 1 usually is suprahysian, at the level of the AV node.
Okay.
So as opposed to, say, the injury we see in patients who've had congenital heart surgery, those patients typically have a higher grade block, usually Mobitz 2 or third degree heart block. This is usually, not the case. So why don't we, since Raymond Morales has been very kind to ask a few questions, Dr. Morales, what would you do if you saw this in your patient who had a cryoablation for AV NRT? What would you say is the next step?
Probably keep them in house and monitor, or send them with the Holter, put a Holter on them in house and then monitor.
Okay, I would certainly agree that I would admit this patient to the hospital, or at least think strongly about it. Patient feels fine. what do you think has happened here? Let me go back to Grace again. Grace, why is this? Is this a normal finding following a cryoablation for AVNRT?
You're close to the AV node. The CKGs immediately after the ablation, Dr. Pass, or?
I think Dr. Flanagan told me that it was a week later during
I see.
post-ablation evaluation.
Oh, then I would likely think the chances of recovery are lower.
Okay, and you're basing that on the timing relative to the ablation, is that?
Yes. Mm-hmm.
Okay. I would agree that the longer out from an ablation, the more likely that what we're seeing is going to become permanent. Why do you think this happened?
Because the area of ablation in AVNRT is so close to the AV node.
Right. So in an AVNRT ablation, we are trying to do what's called a slow pathway modification. And sometimes in order to do that, the fast pathway is very close by, and you can have this happen. Now, first observation I'd make is cryoablation is not supposed to cause heart blocks. So this tracing gives the lie to the notion that one is 100% safe in using cryo. So I would agree with Dr. Morales that this patient should be admitted to the hospital, probably and monitored. I will tell you that if I had this in a patient, I would be very, very upset, especially if I had not seen this during the actual ablation. And the next step that a lot of doctors would do in this circumstance would be to start steroids. And the reason we would start steroids is because of the theory that there may be inflammation. And perhaps as the size of the lesion that you've created and the inflammatory process regresses, maybe the lesion will regress off of the fast pathway and you will have resumption of normal conduction. I believe that's what Lieutenant Colonel Flanagan did, and actually he sent me in the same presentation. There was a tracing showing sinus rhythm with a normal PR interval and no further Wenckebach. I had a patient once in whom we saw this. Actually, I had Mobitz 2 following an RF ablation for AVNRT. It's probably the closest I've come to fainting as a physician. I was very upset in the clinic to see this a week later, but I put the patient on very high dose steroids and thankfully it resolved. But it's always a very worrisome finding when you've performed an ablation and you see something like this. Now, the one proviso is if somebody happens to be very, very, very athletic, sometimes you can have a high vagal tone causing this. But I will tell you, generally speaking, Wenckebach at an atrial rate of about 100 is very unusual. And this is, in an awake patient, this should be considered abnormal virtually 100% of the time. The only time I can ever imagine or remember seeing a patient with this type of finding who had not had an ablation was when I once cared for a patient who was like a Division I 800-meter runner, very fine runner, and she would Wenckebach at slow rates, and she had AVNRT. You could imagine how worrisome that is to go and ablate near someone's AV node where their vagal tone is so high that you at baseline have this. But generally speaking, most healthy, normal people who are not that athletic, and again, that's like nearly professional level of athletics, do not Wenckebach at this rate. And we always assume when we see something like this following an ablation that it's the ablation, not the patient. So a very worrisome tracing. Okay. Why don't we see? I think I saw Neha Lawalia. We spoke earlier in this conference. This is a tracing of atrial extrastimulus testing, 500, 250. And we have here, and again, when you're looking at these tracings, you always want to remind yourself what you're looking at. So in this particular description or example, we have 4 ECG traces. We have a right atrial tracing. This is the His tracing, a single His channel, and 1 coronary sinus channel. So very unusual appearance, but perhaps you can tell me what you think is going on now.
So in the first beat is, as you said, the paced one, and then second is an extra stem, which is with an early beat, and you see an AHV, and the S2, which is the A, you don't see, or you don't see like a ventricular beat following that after the S2. And then again, you see an atrial beat. And I see that arrow in between where that's at the his bundle where it's H, A, and V, which I think it's just like a junctional beat with A in the middle.
Just so I can remind you, over here, they're giving us the cycle length of the R to R interval here, which is 330, right? Which is, close to 200 beats per minute, just FYI.
Right. Trying to. So
this is, and I agree with you, this is, we're pacing at cycle length 500. S1s are considered the drivetrain, and S2 is the extra stimulus. It can also be an S3 and an S4, but in this particular example, just an S2. But we have an S2 at 250, and I agree, the A, there is no obvious V right afterwards, but actually what's happened is that the A to H interval is very long on this beat. So we have AHV, but then we see an A again that's actually preceding the QRS and is in the high right atrium, is on time with the QRS. And then again and again, we have this HAV. This is an example of AV nodal reentrant tachycardia. So we have a jump in the AH interval. I didn't show you 260, but it was about 220 was the AH interval. So you recall that if there's a greater than a 50 millisecond increase in the AH interval with an extra stimulus decrement of 10 milliseconds, that we would call this an AH jump. And what's unusual, or I should say what is specific to AVNRT, is that the A in AVNRT, remember we always say that when you're looking at a surface electrocardiogram, the way to distinguish AVNRT from ORT or AVRT is the R to P interval. And we usually say that if the RP interval is greater than 70 milliseconds, that would be consistent with ORT. And if it is less than 70 milliseconds, it's typically AVNRT. In this case, the A is actually preceding the QRS, or the V in the atrial electrogram. And in the high right atrium, it's on time with it. So the R to P interval is actually negative. The A is preceding the V, and that's because in AVNRT, the reentry is occurring in the AV node, and the time it takes to go from the AV node to the A may in fact be shorter than the time it takes to go from the AV node through the His-Purkinje to the V. And so in this example, the time it's taking to go from the H to from the AV node up to the atrium is actually shorter than going to the V, and therefore we're getting atrial depolarization before we have ventricular depolarization, or almost on time. And so this is an example of a short RP tachycardia, or the most common one, which is AVNRT. Does that make sense?
It does. So after the second beat, that's just the patient going into AVNRT because there's no pacing after that.
I'm sorry,
Like,
say that again. Yeah, that's right. That's right. We're just in AVNRT. We're no longer paced. So in this case, I'm telling you what we did in terms of the pacing, which is 500 to 250. So actually, yes, the R to P interval is where, on the surface ECG, you would not be able to tell that the A is actually preceding the onset of the V, but you should be able to tell when looking at the surface that you can't see a retrograde P wave, that it is in fact simultaneous with the QRS. So yes, this is induction basically of AVNRT. And we can talk about how we could prove that this is AVNRT at our next, it's also possible that this could be induction of atrial flutter with one-to-one conduction with a very long PR interval, right? This could be atrial flutter with this A conducting to this QRS and this A to that QRS. And so that we would have to actually do one or two maneuvers to determine definitively that this is not flutter and is in fact AVNRT. And perhaps next week we can go over how we would do that. This is very pathognomonic for AVNRT, starting with a long AH with a jump. So at this example, we know that the A is almost on time or beating the V, and the heart rate also being a cycling 330, not a very fast form of SVT. Usually AVNRT in adolescence is a little bit slower than orthodromic reentry. So there's a lot of evidence just in this tracing that this is probably AVNRT, but we have not made the diagnosis definitively from this tracing alone. And we can go over next week how one would do that. So I think at this point, the line here. Okay, I guess not. So thank you for joining today. Oh, wait, there is one question. Let's see here. Sound was cutting. I said before we call it a day, does anybody have any questions for me? Thanks. You can hear me now, I guess. Sorry, I'm using my phone.
We can hear.
Yeah, I'm sorry. I'm using my phone for internet access for technical reasons that are kind of stupid. All right. Nice to see everybody. Good morning. And I hope everybody has a wonderful week. See you next week, same time. I'm going to put this up on the YouTube channel later today. Hope everyone has a great day. Take care, everybody.
Thank you.
Thank you.
Bye.
Thank you.